the glucose is still tending to drift down. So the line is not that dissimilar from the person who doesn't have diabetes, but it is set much, much higher. So they're starting off at a much higher fasting glucose, and the argument is that if you give them basal insulin, you will push that line down, you will decrease the area under the line, and the area under the line really corresponds to the hemoglobin A1C value. So that is the rationale for basal insulin therapy, and it's a typical first step because it is relatively simple for patients, relatively simple for doctors who are not that used to using insulin. So a number of things to remember. You should continue the oral hypoglycemic agent. And the question that I'm frequently asked is, well, if you have a patient who's on an insulin secretagogue and you're starting insulin therapy, should you discontinue the secretagogue like a sulfonylurea? Well, my answer is, if I'm only going to give them basal insulin, I would continue the sulfonylurea. Because even though sulfonylureas also have some basal action, they do have mealtime action, which basal insulin will not have. Okay, so you continue the oral agent, and you use the basal insulin to try and optimize the fasting glucose. And up to an A1C of about 9%, you will often be able to get the hemoglobin A1C down to less than 7% with basal insulin. But you need to direct the patient to say that the dose of insulin that I start you on will not necessarily, in fact, will be most unlikely to be the final dose of insulin that you need. So my principles are that I start at a low dose, and then I tell the patient, we're going to monitor your fasting glucose, and every so often we're going to increase the dose of your basal insulin. And we're aiming to get that fasting glucose into the target range of 70 to 130. And in fact, various studies have shown that it's notoriously difficult to get the fasting glucose using this strategy lower than the 115 to 120. And if you try to go much lower than that, patient will start getting hypoglycemia at some time of the day other than fasting. Okay, so there, the basal insulins I've mentioned, glargine, which is Lantus, or Detamir, which is Levemir. Is Levemir available here? I'm sure it must be. In type 2 diabetes, I think you can get away with giving Levemir once a day in the evening. In type 1 diabetes, Levemir often will not act right through 24 hours, and therefore the approval for Levemir in the United States for type 1 diabetes mentions once or twice a day, whereas the approval for glargine is a once-a-day insulin. And you can see the NPH, which really has quite a broad peak. And when you look at those two insulins, because there's effectively no peak with glargine, you could surmise, well, it's likely that you'll get less hypoglycemia with glargine than with NPH. So this was tested in a study called the Treat to Target trial. Patients who were on oral agents were randomized either to receive insulin glargine at bedtime or NPH at bedtime. There were over 700 patients. A1C had to be greater than 7.5% on one or two oral agents. And the target glucose was to get the fasting down to less than 100 milligrams per deciliter. Adjustments were made once weekly by the patient under medical direction, and therapy was advanced unless hypoglycemia had occurred. Here is the algorithm. Everyone started on 10 units a day, and it's very rare starting a patient with type 2 diabetes on a dose of basal insulin of no higher than 10 units, very rare to get hypoglycemia with that dose. And then the dose was incrementally increased depending on what the fasting plasma glucose was. And here are the results. Now, this looks at the overall population of over 700 patients. There's only one line on each of these. You may be asking, why aren't there two lines? One to show the glargine and one to show the NPH. And the answer is that the lines were superimposable. So that's what I said earlier. NPH still can be a very effective basal insulin if given at bedtime. If your aim of the basal insulin is to get your fasting glucose down, then NPH insulin can be effective. But glargine also was effective. So on the left-hand side, you can see the drop in fasting plasma glucose. And on the right-hand side in this trial, you can see the drop in the hemoglobin A1C. So that at the end of the trial, which was 18 weeks, over 50% of the patients had gotten their A1C down to 6.9%. Not quite sure. Okay, so what's the difference between the NPH and the glargine insulin, or the Lantus? And this slide shows you the difference. So they were both effective at lowering the hemoglobin A1C and lowering the fasting glucose. But the NPH insulin, as you can see here, did prove to be more likely to cause nocturnal hypoglycemia than the glargine insulin. And it increased the likelihood of nocturnal hypoglycemia it just about doubled it in comparison to the Lantus insulin. If you look just further along to the right of the slide, I don't know that I have a pointer, but if you look just here, you'll see that there's something which isn't often pointed out, that the Lantus insulin in this study actually increased the likelihood of daytime hypoglycemia in comparison to the NPH. And that's quite logical if you think about it, because the NPH was given at bedtime, which in the United States would probably be sometime on average between 9:30 and 10:30.